Good afternoon, everyone. Thank you for joining tonight's broadcast. While you are joining me, please share this broadcast on Facebook, on LinkedIn, and on YouTube. My name is Marvell L, and I use pronouns he, him, his. I serve tonight as your host and convener for this evening's discussion titled Ring the Alarm, Black, Queer, and Gay Men Response to Monkeypox. For many of you that was aware during COVID, I hosted a series of conversations that addressed the need for education among Black and queer men. And today is no different, and I'm excited about the guests that we have today. As we did not have anything else to worry about, on July 23rd, the World Health Organization declared an emergency for the monkeypox outbreak. On August the 4th, the White House declared monkeypox a public health emergency. On this day, the CDC Director Rochelle Walensky, doctor, said, quote, that this declaration will provide resources and increase access to care. Dr. Stefan Wallace said, and I quote, if people think they aren't at risk for this disease, they are less likely to learn about it and take measures to prevent it, end quote. So the purpose of today's convening is to hear from various levels of our government about the response to this particular pandemic. As a person that is living with HIV, it seems as if this is another thing that we have to face. And so I'm excited to have our guests with us today. My first guest will be Dr. Demetre Daskalakis, who is an infectious disease physician who serves as the deputy coordinator for the National Monkeypox Response at the White House. He works closely with the coordinator, Robert Fenton, to coordinate across agencies to control the monkeypox outbreak. Prior to this appointment, Dr. Daskalakis has served both locally and nationally as a leader in public health, including as the director for the Division of HIV Prevention, Deputy Commissioner for the Division of Disease Control, and the Assistant Commissioner for the Bureau of HIV at the New York City Department of Health and Mental Hygiene. Dr. Daskalakis is recognized internationally as an expert in HIV prevention and has focused much of his career on the treatment and prevention of HIV and other STIs as an activist physician with a focus on LGBTQ communities. Dr. Daskalakis has extensive experience with outbreak response, serving as incident commander during the measles outbreak of 2018 and 2019 and COVID-19 while at New York City Department of Health and Mental Hygiene. He is most recently serving as Deputy Incident Manager in CDC's COVID-19 response. Please help me welcome Dr. Demetre Daskalakis.
Sorry, my mute button was stuck. Hi, thank you so much for the introduction. And I want to first say thank you so much for having me. I'm excited to be a part of this panel and this discussion. I would like to start with just a quick PowerPoint presentation just so we can be on the same page in terms of where we are with monkeypox. And let's see. Let's see. Does that look like a PowerPoint presentation? Great, perfect. So briefly, I just want to go over some of the a quick situation update about where we are with monkeypox that focuses on the current epidemiology as well as some recent updates, new data that I'd like to share. So first, I'll start with the situation update. And so, looking at the number of cases in the United States, we're up to 8,101 cases. That's as of 2 p.m. today, when we closed. Every state and territory has reported cases of monkeypox. Looking internationally, we're just shy of 50,000 cases, so 48,844 cases. And the map shows you the bigger the bubble, the more cases are being seen in the country. So you can see that the U.S. at this point is in the lead with with many of the cases in the world. This is something that's called an epidemiology curve, which really shows what happens in terms of cases by day. And so I just want to show you a trend that's important to watch carefully. So you can see that we have an increase in monkeypox cases and what seems to be a little bit of a flattening. So that's just at this point a little cautious optimism that what we're seeing is that the rate of increase of new cases is starting to decrease a bit. Still means that we have new cases, but that they're not coming in as quickly as they had before, which again is something that some other countries are experiencing. So we'll have to watch it very carefully, but potentially could be a clue that we are starting to see some better control of the outbreak. Again, cautious optimism for that. So, in terms of the current epidemiology, I also wanted to share a bit about race ethnicity. So, these bars show changes in the race and ethnicity of cases in of monkeypox in the U.S. week to week. So, what you can see is that over time, the purple and green bars have started to get larger and larger, and those represent cases among Black or African American individuals or Hispanic or Latino. So purple being Black or African American, and green being Hispanic or Latino. So as you can see, there's a shift. Initially, primarily early on, cases were among white individuals, and it's really the balance has shifted. The majority of cases are in people of color. This is just a view of age and gender. So you'll see that the majority of cases are somewhere between 21 to 45. And when you look at these colors, that dark navy blue represents cisgender men. There are others represented here, but the point of this slide is just to show that the vast majority of individuals who are diagnosed with monkeypox in the US to date are cisgender men. I want to share a deeper dive into the data that actually comes from a report that was published by CDC that actually shows some of the demographic information of people who are diagnosed with monkeypox from May 17th to July 22nd. So what you can see is that of the individuals who had information about their sex partners in the 3 weeks prior to presentation of the men, 94% reported sex or close intimate contact with a man. Of individuals who actually had information about male sexual partners, some of them reported one partner, but most reported having between 2 and 10 partners. Also, some reported having group sex. So that's important because I'm going to tell you a little bit about some of the changes that people reported in their behaviors in the last few weeks. That same report also showed that of the 334 people in that first couple thousand cases, 41% reported living with HIV, and I'll tell you that that number is panning out so far. Hospitalization was also reported in about 8% of people who had a hospitalization status. And at this early date, July 22nd, vaccination status was also reported. And so 14% reported having some vaccine. 23% had the Jynneos vaccine, but only one of the two doses. And others had smallpox vaccination sometime in the past, although we don't have specific details. So I also wanted to show a couple of recent updates. So first on vaccine administration, limited data are available, only 19 jurisdictions so far. But you can see when you look at race and ethnicity, there is a disparity that you can already see pretty clearly. So the top bar represents the number of vaccines given to white non-Hispanic individuals. And you can see that although the majority of cases are among Hispanic and Black folks, the number of vaccines are higher among white non-Hispanic. So that represents a very important disparity that we're really focusing on addressing both locally as well as federally. And I also wanted to share um, data from a survey that showed really the effect of some of the messaging that occurred around ways to prevent monkeypox and the important role of the community that amplified those messages and even made them stronger. What we found in a survey is that gay, bisexual, and other men who have sex with men were actually taking behavioral steps to prevent their risk of exposure to monkeypox. So 48% reduced their number of sex partners, 50% reduced one-time sexual encounters, and 50% report reducing sex with partners met on dating apps or sex venues. At the same time that we released this data that is actually from humans on the street, what we also did was release data of a mathematical model that showed that if you actually do reduce your one-time sexual encounters, you actually see a significant decrease in monkeypox cases and delay in reaching higher levels of monkeypox infection over time, which means that more time for vaccine to actually provide protection. So all of this together really comes to sort of lead to what is the strategy for addressing monkeypox, and it really has to do with a lot like multiple different categories of work. So one is increasing testing, and so I think a lot of work has gone to increase testing. Laboratories that are more accessible to medical providers are providing testing. About 80,000 tests are possible per week. Increasing vaccine. So a lot of strides have been taken to increase the ability of our vaccine supply to cover more individuals. First, by using science and data to change the strategy with which we're administering vaccines. So instead of a deeper shot in the arm, it's a shallower shot that allows multiple doses to be gotten from one vial. Additionally, more production and also new contracts that will allow us to produce vaccine or fill and finish vaccine, so put vaccine into vials in the U.S. Were also announced, all of which will mean that we're going to have a way more consistent stream of vaccination. And the other part of this is treatment. So there's a drug called tecovirimat, which is also called TPOX, that is an investigational drug, so one that we don't have a lot of experience with, but is being used to treat individuals with monkeypox, especially who have severe disease, through a special program through the CDC. We're also at this point launching studies, actually starting in about a week or so, to actually learn better how this drug works. So all of that come together to create a strategy that really works to accelerate control of the monkeypox outbreak. We've also been focusing a lot on interventions that really change the way that vaccine is being given out in the US. So I think a lot of the vaccine distribution that we've seen so far has really been focused on having people find vaccine, and we're really working to sort of shift that into actually having vaccine come to people. We're doing a couple of things and more to come. So one example is that we are actually supporting special events that with additional vaccination allocation. So two really big ones that are coming are Black Gay Pride in Atlanta, as well as Southern Decadence in New Orleans, and there's more in the pipeline. Also, we're working to get vaccine to places where people seek care, and that includes community health centers and HIV clinics that are supported by Ryan White. So, new vaccine allocations have been provided to them as well to move things forward. And this is a space to watch because we're continuing to have innovative strategies to really make vaccine access easier. So, with that, I'll give it back to Marvell. Thank you.
Thank you so much, Dr. Demetre, for that information. Next up, we have Harold Phillips. Harold Phillips is the director of the White House Office of National AIDS Policy, also known as ONAP. In this position, he leads the effort to set the administration's domestic HIV and AIDS priorities. This includes monitoring and implementing the National HIV and AIDS Strategy, consulting with the Office of Management and Budget, coordinating with others on the Domestic Policy Council, the National Security Council, and the Office of the Global AIDS Coordinator to ensure America's response to the HIV epidemic is accelerated, comprehensive, and reflective of the lived experiences of those at risk of and living with HIV. This work is done to reduce the number of new HIV transmissions, improve the quality of life for people living with HIV and in the HIV epidemic. Please help me welcome Harold Phillips.
Good evening, and thank you, Marvell, for inviting me to this really important conversation. Hopefully you can hear me. Again, as Marvell said, I'm the director for the Office of National AIDS Policy. And I'm here tonight as part of this conversation to do a couple of things. You just heard from Dr. Daskalakis about some of the important work that the federal government is doing to improve access to the vaccines for our community. We've been involved at the federal level, I think, trying to ensure that information is getting out to the community. And in my role as the director for the Office of National AIDS Policy, also working to ensure that we have both a comprehensive whole person approach to this new infectious disease that's outbreaking and impacting our community. For those who may be watching who are HIV positive, as the federal government makes more vaccine available, and you've just heard some of the steps that have already been taken and are in place, and some of the steps that are coming very soon, I encourage you, those who are HIV positive in care, to get the vaccine. Those who are at risk, get the vaccine. Those who may not be aware of your HIV status, this is an opportunity for whole person care. Get an HIV test and get access to the vaccine as well for monkeypox. One of the things that we continue to do is, and I think you've heard described here, is try to increase not only availability, but also access. So the use of the Ryan White clinics is one example of places where Black men go for care and treatment, and sometimes HIV testing, where we're working to make it easier for you to also access the vaccine. He also talked about some of the events coming up like Black Gay Pride in Atlanta and how there'll be an opportunity there. So I really and truly encourage you to take advantage of these opportunities and get the vaccine. It's quick, it's easy and safe and simple. The other thing that I think I will also encourage us to do, especially because we have been paying a lot of attention to sort of the syndemic issues, meaning those issues of the intersection of sexually transmitted infections, HIV, substance use disorder, which also impact our community. And I think, as Marvell said, this is something else that's impacting our community that now we have to deal with and face it. I am hoping that with a dialogue like this, that we can face this. We can face it head on. We can continue to learn the lessons from the early days of the HIV epidemic, and really and truly both step up and empower our communities to respond to this. I'm encouraged by some of the data that is showing how there has been some behavior change in some communities, and we also have the opportunity, while that's going on, to roll out more vaccine and make it a bit more available and more accessible. So we'll continue to do the work on the federal level and work in partnership and collaboration with the community as we fight this disease as well. So with that, I will turn it back over to Marvell. I look forward to the Q&A dialogue and hearing from you all too. Thanks.
Thank you. Thank you so much, Harold. I've known Harold for years. As a resident of Memphis, Harold was very instrumental in our Ryan White program with Mrs. Dorcas Young Griffin. So Harold, thank you so much for being a part of this live discussion. Next, as often, I'm a proud person that's from Memphis, and I could not have this discussion without bringing our own health department into this conversation as a spotlight and as a best practice on what our local health department is doing. Dr. Michelle Taylor is the Shelby County Division Director for Health Services. In this role, Dr. Taylor leads the team that plans, organizes, and maintains public health programs and services for Shelby County. She is responsible for the delivery of all public health services and enforcement of applicable health codes and ordinances of Shelby County and applicable statutes and regulations of the Tennessee Department of Health. With a budget of $106 million and comprised of 7 bureaus and 701 employees, the Shelby County Division of Health Services is committed to the improvement of community health, inmate health care oversight, COVID-19 pandemic response, and many other aspects of public health. Please help me welcome Dr. Michelle Taylor.
Hi, Marvell. Thank you so much for having me. It's such an honor to be here with you and to follow such titans in public health like Dr. Daskalakis and Director Phillips. Just a brief overview of what's going on in Shelby County right now. We currently have 30 reported presumptive monkeypox cases. We have vaccinated 353 Shelby County residents. And of those residents that have been vaccinated, 62% identify as white and 36% identify as Black. Unfortunately, on the flip side, we are seeing a disparity in our numbers, and the majority of those 30 cases that I just reported are among people who identify as Black. We are well aware of this disparity, and we're working every day to try to combat that. One of the ways that we're doing it is something that has already been discussed on this call. We're working proactively to reach out to organizations that serve vulnerable populations, including the Black LGBTQ community and the HIV positive community. But you may ask, okay, if that's the case, why is it that the numbers look the way they look? So a couple of things to remember as we get ready for this Q&A session and what's going on here in Shelby County. One, and I know everybody on this call is well aware of, we are in a southern geographic location. We are in a tri-state area. Some people even call it the Bible Belt. And so we understand here at the Shelby County Health Department that there are a lot of stigmatizing behaviors out in the community that we're fighting against every day, particularly as it relates to monkeypox. And even within our provider community. And so the key to battling that truly is education and to going to our Ryan White subrecipients to make sure that we're reaching out to the population who needs vaccination and treatment most. The second thing is funding. One thing to remember about the Shelby County Health Department is a large amount of our funding and all of our protocols come from the Tennessee Department of Health. And right now, we have to follow the guidance of the Tennessee Department of Health, not only in vaccine distribution, but also in things that we're able to do and fund it for. And currently, there is no dedicated funding for monkeypox, but we just received word that we will be able to take some of the epidemiology and laboratory capacity funding that was given for COVID and switch it over to working on monkeypox. And we're excited about doing that because that's going to help us to not only expand testing and vaccination, but also expand to hours beyond normal business hours. And that's the third thing that I want to bring up. We understand that right now we have vaccination appointments 8 to 4:30, normal business hours. And a lot of people, particularly in the Black LGBTQ community, are at work during that time. And we understand that completely. So we're excited that we're going to be able to use some of our previous COVID funding and pull it over to the monkeypox strategy so that we can staff up and hire some folks who will be able to go out to these communities on nights and weekends and outside of normal business hours to really get to the people who need treatment, evaluation, vaccination, and testing the most. So once again, education is key. Funding, dedicated funding for a monkeypox strategy is key, particularly for local health departments like ours. And then having a disparity elimination and health equity approach, which we are well aware needs to happen, mainly because we believe in using a data-driven approach here at the Shelby County Health Department. We're excited that our Ryan White clinical providers have already been experiencing the outreach that we have, and we are hoping that in partnership with them, we will be able to tackle this disparity head on. So with that, Marvell, if you all have questions, I'm ready to tackle those. And it's such an honor once again to be here to answer the questions and to really talk through the unique challenges of being at the local level during this unprecedented time.
Thank you so much, Dr. Taylor. I'm going to add everyone to the screen now to prepare us for some questions. And so just adding everyone. First, thank you all so much for taking out your evening to be a part of this discussion. We definitely already have questions coming in about this particular discussion. And of course, Dr. Taylor, you are up first. One of the comments in the chat is they simply say, I need a vaccine in Memphis. And they do not know where to go get it. When they go to the appointment scheduling system, there are no available slots for the month of September. What does this person do?
So a couple of things to remember about the Shelby County Health Department. Even though we did open up appointments for vaccination, I can say to this group that if you walk into the Shelby County Health Department, you will be worked in to get a vaccination. Okay? You will be worked in. But keep in mind, the reason why we have the appointment system is not to turn people away. It's to make sure that we control the flow and also make sure that those populations who really need the vaccination can get it. And so we have a limited amount of staff who are not only vaccinating against monkeypox, they're vaccinating against COVID, they're vaccinating kids for their school immunizations, they're doing all manner of things. But once again, we appreciate people holding to the appointments, but we also have a little lax in the system so that we can work in those walk-ins. And we're making sure that we're helping our Ryan White sub-recipients. So those Ryan White providers that are in the community, we are helping them to apply with the state to be able to give vaccinations too. So soon, once they are approved with the Tennessee Department of Health, there will be more places to get vaccinations. But I do understand the frustration and the fact that everybody wants it right now. I get it. But we still are beholden to the Tennessee Department of Health too. And so we can only do so much alone. And that's why we are really pulling in all of our community partners from the beginning to make sure that they can get approved to be vaccinators and make sure that we have other providers in the community who can do this work, because we simply can't meet the demand on our own. And that's where I really want to thank our federal partners, because before the protocol change, going from a subcutaneous administration to a intradermal administration. So like Dr. Daskalakis said, going to a more shallow administration meant that we could get more doses from a limited supply. And that's helped us tremendously.
Good. So what I hear you saying, Dr. Michelle, is if someone does not have an appointment, however, feel that they need the vaccine, they are able to walk in the Shelby County Health Department and get that vaccine.
Yes. Or when they walk in, even if they don't get it that day, our staff will work to make sure that you can get it as quickly as possible.
Awesome. Awesome. Thank you so much. The next question came in to Dr. Demetre. Dr. Demetre, a question asked, will the White House provide more vaccines to most impacted communities, such as Black gay folks, Black communities? Will the White House be responsible for the acceleration and the administration of these vaccines?
So first I'll say thank you to thank you so much for Dr. Taylor's comments. Like, it's jurisdictions like yours that make this move quickly. So I really appreciate your partnership and again your enthusiasm because that's what sort of builds confidence in the work that we do. So thank you so much. So the answer to that is a giant yes in terms of the work that we're going to do to make sure the vaccine gets in the right arms. And so I've given you some examples, and there's more coming in terms of strategies to increase vaccine access, specifically among Black and Brown people, given the numbers that I think I shared with you and that you've seen. So I think the first step, which was a really important one, I think Dr. Taylor already commented on, which was like, first, get enough vaccines so we can do things. And so we've done a couple of things in that direction, the sort of the shallower dosing that you heard about, but downstream is coming a lot more vaccine. So we actually just contracted with a whole factory in the United States that's going to get vaccine into bottles and get it in there pretty quickly toward the end of the year, beginning of next, which is not fast enough. In the meantime, though, we have vaccine coming from working to increase production. So that's just getting the access, getting the supply in. But we're actually working with the jurisdictions, and there's more to come on that in terms of really focusing on equity strategies to put vaccines where they need to be. So what I always say is, like, when this started, it seemed as if the way that jurisdictions were dealing with this, because of the limited supply, was they would build something and then people would have to find the vaccine. But we're really trying to shift the equation into like where you go for service, where you go for care, where you go for like events, you're going to hopefully see vaccine more readily. And so I think also the thing that Dr. Taylor talked about, which I've heard so many jurisdictions say, is that once you get to the point that there's enough vaccine to allow for walk-ins, a lot of really good things happen from the perspective of equity, because it really gets rid of that extra layer. And, I actually volunteered a bunch of vaccine events, and, it takes a lot to walk into a place and sort of that says that you're walking in because you're a gay, bisexual, or other man who has sex with men, who, by the way, also has multiple partners. So I think that all of those things that we're doing to sort of get it different places that may be more discreet and aren't sort of in that sort of same public fashion, I think is going to help get vaccine to people. And then I also talked about the stuff that's happening with community health centers. So that's another example. So really putting vaccine close to where people get services and care, including Ryan White, which you heard from Dr. Taylor. I feel like we're on the same script here. Like, when you put things where Ryan White is, you automatically really see improvements in equity because they serve such an important population. So I'll say, watch this space. I've given you a list of some of the things that we're doing, but I'll tell you, when we started this job here, Bob Fenton and I, the president said to me, like, our job is to improve equity of what's happening with monkeypox. And we take that really seriously. And it's been our guiding mission.
Thank you for that. A follow-up question, Dr. Demetre, is that you named, when we talk about high impact prevention, you talked about targeted locations: Atlanta, Pride Being One, Labor Day weekend, and Southern Decadence, which is held in New Orleans. We are approaching the end of Pride season. And so one of the questions is, what happens to rural areas throughout the South? Mississippi, Birmingham, Alabama, Memphis. Our Pride is over. What happens to other jurisdictions, particularly in the rural South, that does not have this large gathering of Black gay folks?
Yeah, so I'll say a couple of things. So one is, like, watch this space, because we're trying to figure out ways to sort of be more micro than macro in terms of some of the equity work, because that's how equity is best done. So, like, you'll see these big events, but the goal is to also see what we can, how small we can go, and still make sense. That's one thing. And the other part is that, there's a lot happening in terms of other strategies that may get vaccine closer to folks. So, like, all of the sort of policy things are being considered. Like, is it possible to think of different kinds of vaccinators that will put vaccine closer? So a lot of conversations are happening in that. I don't have any decisions for you, but definitely that's exactly like where that conversation is coming from, which is like, how do we get to sort of smaller rural jurisdictions? And how do we get vaccine in a way that makes sense for the environment? So I think that you're going to keep seeing like strategies that sort of go more and more micro, and then also say, now that there's vaccine available, what can we do that we know works? Like, can we get this to pharmacists eventually? Can we get it to sort of more rural health centers? So the answer is, like, all of that is being pursued. And the good news is lots of the rural health centers or community health centers through HRSA. So that'll also give us like a little bit of leverage and a lever to move things. So I think that what's important is that like all those the policy parts that need to be discussed are being discussed, but like the energy is there to move things closer to people as opposed to having them try to find the vaccine in places.
Thank you for that. The next question is to all three of you all. At your various levels of government, when we talk about MIPA, the Denver principles, the meaningful involvement of a particular population, the question that was asked at the federal government, at ONAP, and at the Shelby County Health Department, is there a task force that is inclusive of people living with HIV to provide guidance? Dr. D, you can go first, Harold, and then Dr. Taylor.
So I'll definitely start. So I think we're definitely working with a lot of engagement that really focuses on the population that's overrepresented. And so, and again, like, you know, what's important is I think I shared that number about 40% of people who have monkeypox have HIV. Well, that's a lot greater than the population of men who have sex with men even, right? So it's like, it's overrepresented. And so a lot of the engagements that we've done and are working on really focus on like a broad group, including people living with HIV, especially people of color. So I think that those things have been done and will be done more, as well as like very specific engagements that will be recurrent so that we can hear from the population that we're serving.
Thank you. Harold?
So I will say, you know, you read my bio, but one part that you didn't read is the fact that I am a person living with HIV, working in the White House and serving in this role, and didn't just start doing it yesterday. And so as a member of the community, recognizes and understands the importance of having individuals with lived experience inform the work that we do here that sort of gets coordinated out of Washington, and have been working, you know, very closely with the White House team to ensure that there were opportunities for them to hear from members of the public, really think about the strategy, working with Demetre to pull together a list of folks to sort of talk to, hear from, bounce ideas off of throughout all of this, taking emails from folks across the country as things have been coming in, because this has been one of those things that, you know, has been extraordinary in terms of seeing all the different layers of government that needed to come together, not only on the federal level, but also the state and local level to respond, and how the infectious disease sort of was moving throughout the community and across the country at the same time while we were mobilizing forces as well as trying to develop a strategy. But that whole time, getting input from real life folks about what was happening was always and has always been part of the work of our offices as we do this. I think, you know, one of the greatest lessons, and I think for both me and Demetre and also Dr. Taylor, working in HIV, we know the importance of community engagement and involvement, and know that we can make the best plans possible based on limited knowledge, but if we don't have involvement and engagement from people with lived experience, it's not going to work. So from the very start, we've been sort of taking that input and figuring out how to respond to it. And I think a lot of the steps that Demetre is talking about are a result of that understanding that has come from the community being involved.
Thank you so much.
Absolutely. I feel like Dr. Demetre, it's the same thing. We're on the same script. So as part of our Ryan White program, we already have what you called a task force, but we are responsible at the Shelby County Health Department for what we call a transition grant area, which encompasses the tri-state area. So not just Tennessee, Shelby County, but also counties in Mississippi and Arkansas. And so we have a group of folks living with HIV, or people who are concerned about people living with HIV, who we can tap into and make sure that they are providing input to us, and they already do. And so even though you may not always hear about that out front in the media, it's always going on in the background. Community is what we do here, and monkeypox is no different. And so for us, it really is about making sure that we have the appropriate resources to be able to staff up appropriately and do some of those equity approaches that we've talked about throughout the call. making sure that we take vaccine to people, making sure that we talk to providers. And if we're getting anecdotes in the community that people are being turned away, calling those providers to the carpet and saying, listen, you're not supposed to be doing this. You're not supposed to be doing this. Let's educate you on how you can at least evaluate people, how you can be treating with TPOXX, and not just saying, no, I can't see you, go to the health department. We're happy to try to see those folks, but we need other partners in the community to help us with the demand. And so until that gets filled, we will continue to stand in the gap at the Shelby County Health Department with our federal partners and our state partners to make sure that we're taking care of the community.
Thank you. Thank you so much for that, everyone. My next question, and I'll make this the second to the last question, is for Harold. We recognize that in the HIV space, there's been concern around surveillance of people living with HIV. And monkeypox is another registered vaccine. Has your office been able to address some of the hesitancy or the fears of being surveilled?
So I think that's a great question. And it's one that I would say a couple of things about this. You know, I think the expanded use authority gives us the ability to collect information and data to be able to track monkeypox in terms of which communities are most heavily impacted, and also where do we need to make some decisions about additional doses of vaccine that are needed in certain communities. To my knowledge, individuals, perhaps names are not being necessarily collected, but Demetre may have more information on this piece of it as well. You know, right now, I think being able to have access to that data for use, and the data that we get on the federal level is not data that you can identify a particular person. Our data doesn't have that kind of personal information by the time we get it at the federal level. So in terms of tracking individuals in that way, I don't think there's anything to worry about there. But Demetre, I don't know if there's anything else I may have left out that you might want to add to that.
No, I'll just say that I just sort of affirming that that in terms of the data that comes to the sort of federal, the CDC specifically, the information about monkeypox, it's de-identified. So the local jurisdictions, however, use that data for a lot of things, including potentially in some cases contact tracing if it's feasible, but then also the vaccine information. Usually has a couple of sort of elements, which is it also goes into their vaccine information systems, which is then like a record of your vaccine. And then what comes to the CDC has no information about the name of the person who got the vaccine. There will be some demographics attached, which is why I'm able to show you the pretty graphs that show you like where we have disparities and where we have to do work. So, you know, I think it's always a tension. I'll always remind people that like public health tends to be like one of the most secure data spaces that you can ever consider. So like it is like, you know, in terms of like the protections that exist around public health data, it is some of the most like extensive protection. So, you know, I think in the sort of calculus of benefit and risk, the benefit is so great in terms of understanding the outbreak as well as ways to do better with vaccine.
And remember, at the local level, even if we have to collect that demographic information, we're not collecting it to track you in any way. And so it gets de-identified whenever we report it out. You'll notice I said the percentage of people vaccinated because there's 353 people who have been vaccinated in Shelby County, but I didn't tell you the percentage Black, white for the cases. Why? Because we only have 30 confirmed cases. And if I told you the percentages, you may be able to identify who are in that 30. And so, like has been shared, public health is one of the safest places for data because we have so many regulations and rules set up to make sure that people's information is kept confidential and that we're following all the rules to make sure that people can receive the treatment and the vaccinations that they need without worrying if somebody is tracking them or trying to use any information against them.
Awesome. Thank you so much. My last question to all of you all is, are there any final thoughts that you might have, I will give you the space. I know that Dr. Taylor, there's a wait list. So if you could talk about that. But Dr. D and Harold, wanted to say collectively, thank you all so much for taking your time out of your evening. I think, Harold, you are off today after, we've been crossing paths at conferences, and Dr. D as well. And Michelle, Dr. Michelle, I look forward to meeting you at some point in Memphis. But thank you all so much for your time that you're giving to community. And so I wanted to give you the last opportunity to say anything. We can go Dr. D, Harold, and Dr. Michelle. Any closing thoughts?
So I'll start by saying that in general, it's really important to say that the community really inspires all of the work that we do. And so that at every turn of my personal career, I am always stunned at how great the LGBTQAI plus community is in responding to challenges. And this one is no different. And so as we sort of go through this, like seeing how some folks have changed their behavior, seeing how people are so interested in getting vaccines. And then that inspires a desire to make sure there's more vaccine out there so that it gets into people's arms. So I feel like this is just one of those like really great moments that like the community is demonstrating what they need. They're vocal. They need to be vocal, and we're excited to listen and to move as quickly as possible to make sure that the treatment, testing, and vaccine, as well as good advice on how to prevent monkeypox, all come together in a way to really help us control this outbreak. And so it's not an us versus a community. We're all in the community sort of pushing together to get to the end goal, which is to really not have people have the painful side effects and all of the other things that come along with monkeypox. So I want to thank you for the ability to talk to folks, and would love to pass it on to Harold for his always words of wisdom.
Oh, thank you. Oh, I first want to thank you, Marvell, for pulling this together. As you mentioned, Memphis has a very special place in my heart. All of that work we did to establish the Ryan White program, and you as a young leader on the planning council back in the day, still a young leader, yes, but still. And so I'm really grateful for this opportunity to share this information. As we talk about monkeypox, I think one of the things that, like many folks, I had to read up on this and understand it to a deeper level. And it is one of the most painful infectious diseases from all accounts for those who've been impacted by it. In our LGBTQ community, we have one of the highest vaccination rates when it comes to COVID. So when you sort of look demographically and you think about this, and so we know how to line up and get a vaccine. And as gay men who've been involved in public health for a while, I can't stress enough how important it is for us to access this vaccine now. We've talked about it, and primarily a lot of the transitions are among MSM and seem to be sexually transmitted. But monkeypox can also be transmitted by close contact. So I don't have to be having sex with you, maybe. If you got monkeypox and we're in a club dancing and having a great time and sweating or hugging on one another, not necessarily having sex, because sometimes we do hug on one another. That also might put us at risk. So it's really important that we pay attention, access the vaccine. We've talked about there's also a wait list you can sign up in Shelby County. So please pay this some attention. We'll continue to do the work at the federal level to improve access and availability of vaccine, moving the vaccine closer to people so that there are fewer barriers in getting it as well. So thanks again.
And Marvell, I have to echo what my fellow panelists have said. Thank you so much for pulling this together, and thank you for inviting me. Sometimes the local voice isn't always heard, and I feel like the local voice has been heard. And what I want to assure everybody who's on this call is that in addition to doing the things that we know are going to happen, which is increased testing, increased vaccine supply, and increased treatment, the other thing I want to assure people on this call is that the Shelby County Health Department will continue to work every day to use a data-driven approach to root out health disparities everywhere we see them, particularly in this case, and to also call out any stigmatizing behaviors that are some of those barriers to care and to vaccination and to testing that we've been seeing in the community. We're doing that already. We're pivoting as much as we can to make sure that we're taking care of the communities that are at highest risk, but we are also reminding people that this is still a communicable disease, and it means that the people who have it deserve to be able to access testing and vaccination and treatment as much as possible and as barrier-free as possible. So thank you so much for this opportunity to bring the local voice to this conversation.
Awesome. Dr. Demetre, Harold, Dr. Michelle, thank you so much for your time today. And thank you for listening. Please share this on Facebook, LinkedIn, and YouTube. We're broadcasting on 3 places tonight. So thank you, everyone, for your time. Have a good night.
Thanks, everybody.
Bye,
Thanks,
everybody.
Marvell.
Thank
Bye,
you.
everybody. It's good seeing you.